Good morning, everyone. I'm Nelson Freimer, Professor of Psychiatry and Human Genetics at UCLA, and it's my great pleasure today to introduce our speaker, Dr. Carrie Bearden. I've had the opportunity to witness at close hand her spectacular success, starting from her postdoc in the Psychosis training program here to her current role as Professor of Psychiatry and Psychology, Director of the Center for Assessment and Prevention of Prodromal States, Director of the Predoctoral Training Program in Neurobehavioral Genetics, and as an international leader in research in severe mental illness. Before coming to UCLA, Carrie obtained her PhD in clinical psychology at Penn. And since then, she's amassed an extraordinary array of awards and honors. I'll just mention a few of them. The A.E. Bennett Award from the Society of Biological Psychiatry, the Joanne and George Miller Family Endowed Term Chair from the Brain Research Institute at UCLA, Fellowship of the American College of Neuropsychopharmacology, Joel Elke's Research Award from the ACNP. She's a member of the Scientific Council of the Brain Behavior Research Foundation. Carrie's made major contributions in two related research areas. First, developing more precise and biologically meaningful approaches for phenotyping in genetic studies of severe mental illness, an area in which I've had the privilege to work closely with her for the past 15 years. And second, studies focused on elucidating neurobiologic mechanisms and improving outcomes for individuals at high risk of psychosis. She's going to speak today about the latter topic in a presentation entitled Early Identification and Intervention for Youth at High Risk for Psychosis. Please join me in welcoming Dr. Bearden.
All right, I think am I unmuted now? All right, and I hope everyone can see my screen okay. Wow, Nelson, thank you so much for that, that beautiful introduction. And I want to thank Nelson for being an incredible mentor for me over my time here at UCLA since I started here almost 20 years ago now, which is a shocking thing to say. So the title of my talk, Early Identification and Intervention for Youth at High Risk for Psychosis. I added this clause, obvious, effective, and overdue. This was from a commentary from my colleague, Pat McGorry, and I think it's I think it really captures the moment, and I hope by the end I'll convince you of this as well. And my email address is on the bottom of the slide, so I love to hear from you. Hopefully we'll have some time for discussion at the end of my talk as well. I am actually on the UCLA campus right now, which is weird. So even though I'm not seeing you all in person, unfortunately, I have no disclosures. But before I start, I just have to give an enormous, just heaps of great gratitude and praise for my incredible team in my lab and the Center for Assessment and Prevention of Prodromal States. You folks are incredible and make this work possible, and I'm just so grateful to work with you all. And of course, also our international team and my colleagues in neurobehavioral genetics, particularly Nelson, and obviously it takes a village to do this work. So I don't think it will come as a shock to anyone here in this audience that the societal and personal costs to families of having a family member affected with a psychotic disorder are monumental, over $155 billion annually for schizophrenia in the US alone. And this includes caregiver costs as well. Reduced quality of life is really substantial, social isolation, vocational impairment, incredible challenges for families, as well as premature mortality. People with serious mental illness, particularly psychotic disorders, have reduced life expectancy by 12 to 15 years, which is a really shocking statistic, as well as very high rates of suicide, particularly in the early phases of illness. So why are we interested in studying at-risk populations? Well, we know that neurodevelopmental factors are clearly relevant to schizophrenia etiology. And in fact, individuals at risk for the disorder display these more subtle signs of impairment in cognitive, motor, and social emotional development long before the onset of full-blown illness, which would suggest that the onset of these overt symptoms is actually a late stage of the illness. And we really ought to be identifying people back here in order to hopefully intervene before these pathological processes have fully unfolded. And so we're hoping that by advancing understanding of these early risk factors, we may be able to modify the course of illness, particularly if we can intervene in these early phases. So that's really the goal. And in terms of early intervention, a primary goal is reducing the duration of untreated psychosis. So in an earlier meta-analysis, the mean duration of untreated psychosis was found to be over a year. Of course, there was a very big range. And so I thought, well, maybe this has gotten better more recently, but in a more recent meta-analysis, it was still 61 weeks. Again, a lot of variability. And the duration of untreated psychosis, another review found it didn't differ as a function of gender, identity, or ethnicity, which I guess is good, but apparently, it's sort of bad all around for everybody. And there was also some nuances to this, as it does appear to be this duration of untreated illness significantly longer in highly urbanized areas, as well as for first-generation immigrants. So that's really important. We know that this prodromal period preceding the onset of full-blown illness is associated with substantial functional deterioration, as well as high rates of suicide. And earlier treatment in patients with psychosis is associated with, interestingly enough, a better response to medication, lower likelihood of relapse, reduced suicide rate, and better clinical and functional outcomes over the short and long term. So this would suggest that early intervention may arrest or at least attenuate these deteriorative aspects of the disease process. And so in medical disease, early intervention, of course, is a major factor in reducing morbidity and mortality. And the severity or the invasiveness of that intervention really scales with how early you can get in there and intervene. So can early intervention before the onset of overt illness lead to even better outcomes? And that's certainly the hope. So the other thing to highlight here is there's this really interesting phenomenon for early psychosis, where there is this gap between the level of functional disability in terms of work, school, and social function and the severity of symptoms. So in this prodromal period, essentially people may start withdrawing socially, they have trouble concentrating, going to school, which can have a lot of important consequences for adolescents. And this is a key time period for establishing identity, getting a job, and so forth. So even though the symptoms aren't so severe, there's a lot of functional impairment. And then you have symptom onset, where symptoms really increase. But even when those symptoms are hopefully treated, that level of functional disability really persists. And this is something that our existing treatments really do not do a good job with. So how do we ascertain individuals believed to be at imminent risk for psychosis? We use a semi-structured interview that is called the structured interview for psychosis risk syndromes. And what's nice about this interview is that it assesses dimensional severity of subthreshold to fully psychotic symptoms. And of the people who meet criteria based on this interview for a clinical high-risk state, about 15% will develop a psychotic disorder over 1 year, 30% by 2 years after ascertainment. And of those who do convert, about 80% will develop a schizophrenia spectrum diagnosis, 20% a mood or atypical psychotic disorder. So when we think about these essentially 3 pillars of prevention, we have prediction, mechanisms of onset, and intervention. And so I'm going to highlight each of these a bit in my talk. And so one of the areas that I really appreciate about doing this work is that our clinical and research goals can be pretty well integrated. From a clinical standpoint, we're really interested in improving functional outcome. And research-wise, we're interested in identifying neurobiological markers that can help us better understand etiology and hopefully develop more neurobiologically targeted treatments. So this is the website from our program, from the CAPS program. And these are some of the symptoms that we point out on the website. Sorry about the background noise. One of the challenges of being at UCLA. Have you noticed some of these recent changes? Odd behavior, withdrawal from friends and family, subtle or pronounced suspiciousness, hearing voices or seeing visions, diminished or blunted emotional reactivity, and so forth, falling behind at work or school. And so you can see that some of these are fairly non-specific. So this is why it's a little bit challenging to ascertain these individuals who are in this early risk state. And this here, something is not quite right. This was the education campaign in Canada for getting help for early mental illness. And this really encapsulates very well, I think, the experiences that a lot of the young people that we see are going through. It's very difficult for them to explain, but it's very distressing. And so our program has been around since 2001, and participants are referred to us from community agencies across California. And this is sort of where our referrals are coming from. A lot are in existing treatment, but their treatment providers feel that something else is going on. And this is either from private practice or from UCLA. 15% are self-referred, and then others from friends and family. And for those that are included in our program, over the past 5 years, we've evaluated 274 individuals. About 41% meet our criteria. We've gotten a lot better at this over time. Our coordinator, Monica, I have to give a shout out to Monica, doing an outstanding job, really doing phone screening. And so anyone who's we determine is actually probably not going to be eligible, we're able to refer them elsewhere to other programs. And so of those who do not meet the criteria that we evaluate, about 30% is because they have something else is going on, depression, anxiety, ADHD, and so forth. And then another almost 30% is because they already have fully psychotic symptomatology. And when we first started this, that really surprised me that people could completely, unbeknownst to their parents and family, have a full-blown psychotic illness. But now that we've been doing this for a while, it's not so surprising. And fortunately, we have, for adults, we have Keith Nocturline's aftercare program is a great place to refer. And we do also have, we started a program for adolescents with psychotic disorders because of this. So they have another place to go. So this is our, just to give you an example from the structured interview for prodromal symptoms, the symptoms are rated, the positive symptoms on which the diagnosis is made are rated on a severity scale from 0 to 6. And the severity depends on a lot of factors, the frequency and duration of symptoms, how preoccupying they are, as well as the cultural and environmental context. And I really want to emphasize that. This interview does take a long time because that's a really critical consideration. So for someone who's experienced a suspiciousness, but they live in a dangerous neighborhood, for example, we wouldn't want to pathologize that. So the positive symptoms that we rate are unusual thought content, suspiciousness, grandiosity, perceptual anomalies, and disorganized communication. And the interview also assesses negative, disorganized, and general symptoms. We get a pretty full picture of what's going on. So if you take a symptom like unusual thought content, there's a number of questions we ask. And so, for example, confusion about what if you're experiencing is real or what's imaginary. And so at a prodromal level, this would be sometimes they can't tell if something that happened was real or if it was from a dream. And then we ask about another example, ideas of reference. So at a fully psychotic level, an idea of reference is, I am totally convinced that the way this furniture is arranged in this room is trying to send me a message, a coded message, and you cannot convince me otherwise. Whereas at a prodromal and moderate level, it might be something like, I see this billboard every day and I'm starting to think that maybe it's a special message for me, but I'm really not sure, but it's starting to freak me out. So that's just to give you an example. So the North American Prodromal Longitudinal Consortium, or NAPLES, this is our multi-site prospective longitudinal study. I'm going to be telling you about some of these findings. We've been conducting identical assessments across sites where we follow people meeting these clinical high-risk criteria for 2 years. And some of the major goals of this project are really to refine our algorithms to be able to better predict psychosis prospectively in at-risk youth. As I mentioned, with the current clinical high-risk criteria, it's about 30%. will develop a full-blown psychotic disorder, but that's certainly, we ought to be able to do better in terms of prediction. And then also to assess biological markers that may improve our clinical predictive algorithms. And here we want to determine whether these neurobiological abnormalities are stable. Is it something you detect at baseline and that predicts outcome, or are they progressive and sort of tracking with illness, with symptom progression? So in Naples, too, we recruited across sites. This is across North America, 734 individuals meeting our clinical high-risk criteria. 68 of these were followed for a full 2 years and developed a psychotic disorder. 280 demographically matched controls. So on average, they were about 18 to 19 years old, pretty evenly distributed, male, female, and it was a pretty diverse cohort. About 15% Black, 18% identified as Latinx, a little over half white. And these were matched across cases and controls. So I'm just going to highlight some of our key findings, first in the area of clinical prediction. So when we talk about prediction, we're usually talking about a group level on average. But if you're having symptoms, you go to see a doctor, you really don't want to know about an entire group of people. You want to know what this means for you personally. So we teamed up with Michael Catan at the Cleveland Clinic, and he's developed these algorithms for individual risk prediction for various kinds of cancer and cardiac disease. And so we worked with his team to develop an individual risk calculator for psychosis. And so we found with this that there were actually a couple of symptoms. This was P1, unusual thought content, P2, suspiciousness, decline in social functioning, as well as a couple of neurocognitive measures. This is a verbal learning and memory measure. This is a processing speed measure. And these really carried the greatest weight in our predictive algorithm. And this is the risk calculator is now online. So if you have this information for someone you're seeing, you can plug it in and get their individual risk of conversion to a psychotic disorder over a 2-year follow-up period. And what you can see here is the 2-year probability of conversion to psychosis, the area under the curve, which is essentially our classification accuracy of 71%. Not perfect, but it is significant. And the other thing I want to highlight here is that this compares very favorably to an algorithm for prediction of breast cancer recurrence. And so, in other words, what's important here is that even though we don't have a lab-based diagnostic test for psychosis or for clinical risk for psychosis, we're able to achieve comparable predictive accuracy. So what about biological markers? So can neuroimaging help us improve these predictions? Well, these are data from my colleague Frank Sun, who's currently at the West LA VA. These are looking at, what we're looking at here are longitudinal changes in gray matter over the first year after psychosis onset. These are first episode schizophrenia patients, these are controls. And this difference map, these areas in red, are showing you the areas where there was a greater loss of gray matter in individuals with schizophrenia. Now, again, these are people that already had a schizophrenia diagnosis, and these are showing this accelerated gray matter loss over that first year of illness compared to typically developing individuals over that time period. Now, we don't know the cellular basis for these changes, but one possibility is a process of overly aggressive synaptic elimination. So we were very interested in whether this was something that we could see in people that are at clinical high risk for psychosis. So is neuroanatomic change actually predictive of illness onset? And so here we're looking at cortical thickness changes over time among those who converted to psychosis over a 1-year follow-up compared to controls, and then compared to those who did not convert. And so what you can see is that these red and yellow colors are the areas where there was greater gray matter loss in those who converted compared to the controls. And so you can see it's a very similar pattern in those who had similar symptoms at baseline but did not convert. And so these gray matter loss, increased gray matter loss is really seen in these, particularly these medial frontal and a little bit in superior temporal gyrus. Another thing to point out is that we saw differential gray matter loss among cases who had not received antipsychotic medication during that interscan interval. So it's not a medication effect. And also interesting, this prefrontal gray matter loss was significantly correlated with the pro-inflammatory index in plasma from peripheral blood. Again, correlational, not causation, but suggesting there may be something about neuroinflammation that's relevant to this process. Now, again, we have here receiver operating characteristics showing the overall classification accuracy for this gray matter loss phenotype, which is 71%. If you remember a couple slides ago, interestingly enough, identical to what we saw for our clinical predictive algorithm. So that really begs the question of, do we get increased predictive accuracy if we are, you know what, maybe I can, sorry, I don't know if you can see that, but I just moved my little screen tool. We get the best multivariate model of gray matter decline and clinical variables. So we put in unusual thought content, suspiciousness, verbal learning and memory, and our prefrontal gray matter decline phenotype. And we actually do get a significant increase in our predictive accuracy of this model, up to 76%. So with this, and what you can see is that there's a few of these natural cut points on this receiver operating characteristic curve. So if we want to only identify, now if we really don't want to be wrong, if we don't want to identify any false positives, we're only going to detect about 18% of converters. But if we can tolerate a little bit of a higher level of false positives, we will get up to 80% of converters up here. So this is one of these trade-offs that we really have to think about in terms of what, you know, there is certainly a cost to informing a family that their child is at high risk for developing a psychotic disorder in terms of stigma, in terms of increased anxiety and so forth. So this is something that we think about a lot in this field. So moving on to another brain imaging index, schizophrenia as a disorder of distributed neural connectivity. So in other words, what are the functional implications of these structural brain alterations that we've seen? There is a large body of evidence now conceptualizing schizophrenia as a disorder of distributed neural connectivity involving these widespread disruptions in neuronal communication. This has been interrogated using a method called resting state functional MRI, which is a measure of spontaneous fluctuations in neural activity. And interestingly, the thalamus in particular is a brain structure that's of considerable interest in schizophrenia, as it's a central communication hub in the brain, responsible for relaying information from sensory receptors to the proper brain areas. And these thalamocortical circuits really represent a fundamental aspect of large-scale brain organization across species. And there's a wealth of evidence for thalamic abnormalities in schizophrenia from neuropathology studies. They're also implicated in sensory gating deficits we see in schizophrenia patients with electrophysiology studies. And the thalamus may be particularly sensitive to network level disturbances. Now, interestingly, NMDA receptors also may have special importance in the thalamus. And the NMDA receptor hypofunction hypothesis of schizophrenia really originated with the finding that NMDA receptor antagonists can induce, at least transiently induce, positive, negative, and cognitive symptoms of the disease in humans. And we know that these NMDA receptors innervate at the hippocampus, causing dopaminergic release. So we were very interested in this thalamocortical connectivity as a potential, having potential relevance to disease. And when we, this was a study from my colleague Alan Antichevich at Yale. And what Alan did was to look at this essentially this dichotomy between sensory overconnectivity of the thalamus to sensory areas versus underconnectivity shown in blue with these prefrontal, striatal, and cerebellar systems. And so this pattern has now been highly replicated across studies. And so we were interested in whether we would see something similar in prior to disease onset. So again, that was in people with established illness. So do we see the same pattern at baseline prior to the development of disease? And so what we're showing here is these yellow areas are these areas of overconnectivity of the thalamus, and blue are showing areas of underconnectivity, hypoconnectivity to these medial frontal regions. So essentially a quite similar pattern to what was seen in people with established illness. And then when we look at, let me walk you through this here, what I'm showing you. This is looking at these different regions of interest. And what you can see here is the overall pattern of functional connectivity in those at clinical high risk, shown in purple, who did not convert. So they were symptomatic, but did not ultimately develop psychosis. And those shown in red are those who subsequently did convert to a full-blown psychotic disorder. And so what you can see is that this pattern of excessive over and under connectivity is really being driven by those individuals who subsequently converted to a psychotic disorder. So this pattern of functional disconnectivity is present before the onset of full-blown symptoms. That's really, I think, the important bottom line. Now, you may be familiar with the term polygenic risk score. And so from the genetic standpoint, we're also interested in whether polygenic risk score might improve our prediction. So what a polygenic risk score is, it really reflects the cumulative genome-wide impact of common genetic variation on a given phenotype into a single measure of genetic risk. So it's essentially the sum of the odds ratio for each variant. And so if you're looking at this Manhattan plot here from a genome-wide association study, essentially what we're doing is taking each of these SNPs, each of these single nucleotide polymorphisms, summing them up into a p-value and an odds ratio across the genome. And that score will give you this distribution where a polygenic risk score for schizophrenia. And so patients, there's a distribution, but patients will score significantly higher in terms of polygenic risk for schizophrenia than controls. And so what we were interested in is whether our clinical high risk individuals, whether those who subsequently converted would have a higher polygenic risk score for schizophrenia than those who didn't. And well, there's been a number of studies now looking at polygenic risk score as a potential clinical implications of polygenic risk. So for example, for breast cancer, and it's been, I think, more recently looked at in the context of risk for serious mental illness, but certainly this is an expanding area of interest. And this certainly has utility, or well, I don't know about certainly, it potentially has utility for identifying those who could benefit from knowledge of probabilistic susceptibility to disease. So here we looked at the schizophrenia polygenic risk score contribution to psychosis prediction in our clinical high risk youth. And another actually important caveat I need to mention here about polygenic risk scores, these were developed primarily overwhelmingly on European individuals, which is really a problem. We are attempting to rectify this now. Nelson and our collaborators in Latin America are working on, collecting much larger populations of people of different ethnic backgrounds, also groups working now in Africa. But the bottom line is that for this study, we had to look separately at those of European and non-European ancestry because of this issue of the way these polygenic risk scores have been developed so far. So assuming a 2-year psychosis risk of 10 to 30%, we get a liability for Europeans of 9 to 12%. For non-Europeans, again, this polygenic risk score does not work as well. So it's a little less than 5%. But essentially what this is showing us is that the polygenic risk score is indeed significantly higher in those high-risk individuals who subsequently develop a psychotic disorder compared to high-risk individuals who do not, and they did not differ from the healthy controls in terms of polygenic risk. So it does suggest that this may be something that we can add to our model in terms of improving prediction. And also importantly, a bipolar polygenic risk score did not predict psychosis conversion. So it appeared to be relatively specific to the polygenic risk score for schizophrenia. Looking at this a different way as a survival analysis, we found that psychosis conversion stratified, looking at psychosis conversion stratified by polygenic risk score. So conversion risk was highest in those with the polygenic risk score greater than 1.5 standard deviations from the mean. Intermediate in those with intermediate polygenic scores and polygenic risk scores, and lowest for persons with scores less than the mean, shown here. And again, it didn't work quite as well in those of non-European ancestry, but we did see a similar pattern. So essentially, our risk calculator model, when we add polygenic risk score to the model, it performs better than the risk calculator model alone. So the amount of risk prediction information that's contributed by adding polygenic risk is about 15% for Europeans, 7% for non-Europeans. So it's not nearly as good as those top clinical predictors, unusual thought content and paranoia, but it's better than some of the other predictors like the cognitive ones. So it certainly does contribute something to the model. Okay. And this is actually data that's not from our Naples consortium, but this is another collaboration with Cheryl Corcoran at Mount Sinai, and looking at, this is an automated classification of language, machine learning classification of language. And what we found here was that this classifier comprising decreased semantic coherence, so greater variance in semantic coherence, reduced usage of possessive pronouns, things like her, his, mine, etc., was highly accurate in predicting subsequent psychosis onset. So I just want to point this out as another potential really interesting biomarker for predicting subsequent onset of psychosis. So why are we so interested in identifying these biomarkers? Well, we can consider this as something like a Koplik spots of psychosis in terms of biomarker discovery. So Koplik spots are a very specific diagnostic indicator for measles virus. So these little spots that appear about 2 to 3 days before measles shows up. So this hunt for the elusive Koplik spots of psychosis, that is biomarkers that can reliably predict illness development. And when we talk about a biomarker, ideally, this is something that reflects an underlying pathophysiological or mechanistic process. And biomarkers, the goal is that these really can facilitate treatment development by providing molecular targets for intervention based on disease mechanisms. They can also hopefully provide a fast fail testing strategy. So these biomarker candidates can be tested for effects on, or drug candidates or any kind of treatment candidates can be tested for effects on the biomarker before a large-scale clinical trial. And subgroup identification hopefully can be based on disease etiology. But then I want to point out that while we're working on this, while we're attempting to come up with these really great effective biomarkers, we don't just sit on our hands and wait. There are effective treatments right now. And so I'm going to get to intervention in a bit. First, I just want to summarize this part of the talk. In terms of clinical high-risk paradigms, these paradigms are useful for elucidating predictors and mechanisms of onset of psychosis. These prodromal criteria, while they're certainly far from perfect, they are among the most powerful risk factors for psychosis that we have to date, giving us a relative risk of about 200. Of course, the multivariate combination needed for perfect discrimination, we're not there yet. These biological markers may improve our risk assessment. We have dynamic biological markers like gray matter loss and other measures that are baseline predictors like polygenic risk score, potentially language, potentially functional disconnectivity that are possible candidates. It's really important that we are able to represent multiple risk profiles and molecular pathways, as one of the big challenges of this work is heterogeneity. So sample size is certainly a challenge. So multi-site studies is what we've adopted to try to deal with this challenge. We also need to intervene. We can't just sit by and naturalistically observe people who are in need of treatment. So this is another a challenge. And so we try to integrate treatment with our prospective longitudinal follow-up. And then, as I mentioned, heterogeneity, both of outcomes as well as of risk profiles. This is certainly a challenge for the field. And so one thing that we can do, or we're hoping to do, is more stratification, either by genetic risk or biological or etiological subtypes. So where does that bring us? Well, in 2019, we heard that there was a plan afoot to develop what's called an Accelerating Medicines Partnership, or AMP, for schizophrenia. And so the goal of the AMP is to bring together resources of the NIH and of industry partners to improve our understanding of disease pathways, facilitate better selection of targets for treatment. And there have been these AMP programs for other disorders, for common metabolic diseases, for neurodegenerative conditions, Parkinson's, Alzheimer's disease, as well as for some autoimmune disorders. This AMP schizophrenia is the first for a psychiatric disorder, so it's really exciting. It's also terrifying, but it is really exciting. I feel a lot of pressure to get this right. So there were requests for applications from the NIH for research networks, as well as a data processing analysis and coordination center. And so this call came out in late 2019. And so they essentially leveraged between the NIH and private sector partners $82.5 million for this AMP schizophrenia initiative. So these are the private partners that didn't run away screaming from a CNS disorder. We also have NAMI and One Mind, who are patient advocacy nonprofit groups, which I think is really important. The APA is also involved. And so the goal of this Accelerating Medicines partnership, we know, and well, hopefully I've convinced you a little bit that the clinical high-risk state is increasingly recognized as a valid diagnosis associated with serious adverse health outcomes. And there are an increasing number of specialized clinics worldwide, but there really are no registered or validated treatments, medication or otherwise. The psychosocial treatments I'll talk about a little bit at the end. But the goals of this AMP are really to develop tools to identify or stratify our clinical high-risk populations and evaluate the efficacy of treatments. So the importance of biomarkers that may allow us to stratify our heterogeneous patient population into more into enriched or etiologically coherent subgroups. And so developing these research networks, the goal is to provide a proof of principle for pharmacologic or other intervention studies using tools generated from this project. The other thing, as I mentioned, the heterogeneity, it's also really important that we treat other symptom domains in addition to psychosis. This is those at clinical high risk for psychosis have a lot of comorbid depression, anxiety, and other diagnoses as well. So this was our application in terms of the model that we put forth. We have some potential disease mechanisms here, NMDA receptor hypofunction leading to excitatory inhibitory imbalance and downstream neural disconnectivity. And again, highlighting this great heterogeneity in terms of trajectories and outcomes. And so this heterogeneity both before and after ascertainment. So some of the goals really to determine the time course of these various actionable clinical high risk outcomes, including positive, negative, as well as mood and anxiety symptoms. Functioning is an important goal, looking at remission and conversion, and to create these robust multimodal biomarker-based stratification tools that map onto outcomes and clinically relevant trajectories for use in future clinical trials. So this is the organizational structure. I'm just laughing here because when I first, we were working on this grant and I showed this in a lab meeting, someone commented that it looked like we were putting together a plan for government of a small country and not writing a grant, and they are not wrong. We have myself, Scott Woods at Yale, and John Kane at Northwell are the PIs, and we have 26 sites internationally. They're really great people to work with. And then we have a number of science cores for each of our biomarker domains. And so I won't belabor the details here, but essentially this project is now underway. Ours is called the Psychosis Risk Outcomes Network, or PRONET. These are our international sites. And in fact, the NIH funded 2 research networks, ours as well as one that's their hub is in Australia, led by Pat McGorry and Barnaby Nelson, and it's called Prescient. And so we have sites across North America, Asia, and Europe, 42 international sites. And our goal is to enroll 2,000 clinical high risk individuals between the ages of 12 and 30, 500 demographically matched controls across sites that we will prospectively follow over 2 years. And in partnership with the AMP. And so we are just getting started, but this is what we're planning to do. We have our neuroimaging protocol, we have EEG, fluid biomarkers, DNA, plasma from blood, salivary cortisol to look at stress reactivity, cognition, natural language processing. There's a big digital health component using a platform called LAMP, both active real-time symptom, ecological momentary assessment measures, as well as passive measures like activity and sleep. And we're going to be assessing people twice over a 2-month period to look at both static and dynamic prediction. So essentially, this is the project and the timeline. So 2 of these 3 projects within the AMP Schizophrenia Research Plan have been launched. That is the data analysis core and our research networks. When I say launched, I mean that we have started. We've had to harmonize our networks. We wrote 2 totally different grants, and now we had to make them into one project. So it's been a fun process. But it's a great group of people to work with. So essentially, the next stage, once we are able to actually start collecting data, it's been delayed by COVID and various other logistical issues, but we are getting very close. And so then essentially project 3 is these proof of principle clinical trials to test the utility of tools and the hypothesis. And so that is this go no go decision is expected in sometime in 2023. So that's the current plan. We'll see what happens. So that's what we're working on now, which I think is really exciting. But I want to talk a little bit about interventions while we're working on all these really exciting biomarker-based, validation of these different biomarkers. We do have treatments that are effective, and I think that's a really important point. So family-focused therapy, this is a treatment that was developed by my colleague, David Miklowitz, originally for offspring of bipolar parents and youth with bipolar disorder. It actually translates really well to the clinical high risk population. So in general, the goal of family-focused therapy, it's in a clinical setting, it's 12 to 21 outpatient settings over 4 to 9 months, sessions with youth and their family members. And then the goals really are for active treatment are establishing a family prevention action plan and reestablishing and strengthening functionally family relationships. So improving family communication is really the key component of this. And so there's a number of handouts that the families get regarding, and so basic communication skills are a big part of this. And while I'm talking about this, I want to just give another shout out to my team for our team at CAPS for translating these materials, these handouts into Spanish. So Spanish speaking families can also participate in this treatment. So I think improving access to care and really reducing the barriers to treatment has really been a big goal, and I'm very proud of what we've been able to do there. So this is what we found with our pilot study. This is work led by David Miklowitz. So essentially with the active treatment condition, this family-focused therapy, CHR, we found that over a 6-month period, the youth who received the active treatment, the family-focused therapy, had a significant reduction in positive symptoms and improvement in family communication. Now, those in what's called the enhanced care condition, they also got better. Just the group with the family-focused therapy showed differential improvement. And the other interesting thing about this treatment is that those individuals who were deemed at higher risk based on our risk calculator actually improved more with the active treatment condition with family-focused therapy compared to those in the enhanced care condition. And lower risk individuals didn't differ in symptom improvement across treatment groups. So it really does suggest that stratifying treatments based on particular symptom profiles and risk profiles can be valuable. So we're now doing a new, larger confirmatory efficacy trial that's called Understanding Prodromes and Lessening Illness in Family Therapy. It's a multi-site study. UPLIFT is the really nice acronym. So that is currently underway. And so we are both we're doing biomarker studies, but I think doing these psychosocial interventions is also a really critical part of the program. So just to wrap up, this prodromal period prior to full-blown illness offers a key window in which to intervene. And we know that this prospective identification is challenging, but it can be done. And critical neurodevelopmental processes during adolescence are likely disrupted by psychosis onset. Gray matter loss, we think maybe an early dynamic biomarker indexing early phases of illness. The other we see other factors that provide these promising baseline, that is stable predictors, such as polygenic risk, as an example. The precise complement of risk factors leading to schizophrenia may be personal to the individual, but observable in aggregate across individuals. And ultimately, so intervention is really the ultimate goal, and ultimately precision medicine for these etiologically defined subtypes. But I want to highlight again that psychosocial treatments are effective in symptom reduction and improving functioning. So there is a lot we can do while we're trying to better understand disease etiology. And so lastly, I just want to thank the NIMH, as well as the Levin Trust, the Sheer Family Foundation, and NARSAD, as well as all the patients, their families who participated. Obviously, we couldn't do this without you. And again, big thanks to my team. And I'm going to stop there for questions.
Okay, so thanks very much, Carrie, for that incredible tour de force. So people have questions, please use the Q&A function in Zoom. So far, I don't see any, and so I'll start with one, which is really to sort of ask you to, like, how you might see the two parts of what you've talked about coming together. You mentioned at the end the intervention study that you're doing with David Miklowitz. Do you have any thoughts about how to see whether any of the biological information might be used to sort of identify who might best benefit from that versus some other approach?
Yeah. That's a really great question. So I think that the one example that suggests that we can sort of integrate these approaches is that taking that clinically based risk calculator and looking at individual scores in the risk calculator really did show that the people who were most likely to benefit from that family focused therapy were the ones that had the highest risk calculator score at baseline. And that was, again, a clinical risk calculator. So I think that, for example, if we can incorporating, and what we're doing now is incorporating these biological markers, as well as, things like polygenic risk score into the risk calculator, would suggest that people who have this, perhaps biologically based higher risk, may be more likely to benefit from these either more likely to benefit or more likely to need these very active intensive interventions. I think the other thing that I would say is that this gray matter loss finding, while we don't fully understand the cellular basis for it, I think that it may be something that really does track with illness, with symptom progression, and so it may be a way to really determine whether someone is responding to a treatment or not.
Okay, thanks, Carrie. Mm-hmm. Okay, so now I'm going to turn to some questions from the audience. The first one is, we're often focused on conversion of psychosis, mostly schizophrenia spectrum illnesses. How do you think those who do not convert to psychosis but still have high symptom burden could benefit from schizophrenia? Yeah,
that's a great question. And well, not just me, but I think we completely agree and acknowledge that the focus has been on an outcome has been predominantly and probably too much so on conversion, particularly given that that really is only about maybe 30% of those who are followed who meet those clinical high risk criteria. And so I from a psychosocial intervention standpoint, I think that regardless of the ultimate trajectory, I think people benefit because one of the big targets is improving social and role functioning. And so one of the things that we found when we look at the people who do not convert over that 2-year follow-up period, the ones who are still doing poorly in terms of social and role functioning are those who have higher burden of depression and anxiety. So certainly, I think treatments and our treatment focus tends to be pretty individualized in terms of what's most clinically indicated. Even in the context of a family-focused therapy, we stay pretty symptom-focused. And so I think that the highlighting symptoms like depression and anxiety, and understanding their impact on social and neural functioning, I think is really critical. And from a biomarker standpoint, I think that we are focused on biomarkers that predict psychosis outcome, but I think we're going to learn a lot about biomarkers that predict other outcomes as well.
Okay, thanks. Okay, next question. At the prodromal stage, are there pharmacologic interventions that show promise of prevention?
Good question. So, this is a challenging area because very early on, when this field first started, there was a big interest in antipsychotics and whether antipsychotics might be preventative. There have been a couple of antipsychotic trials. The biggest one was, I believe, for Zyprexa. And one of the challenges was just the really huge dropout rate, and also the metabolic side effects. So I believe the average weight gain was about 12 pounds in youth. And so it did actually significantly reduce positive symptoms, but there was a pretty high cost in terms of adverse effects. So the staging model that we advocate for, and that I think our colleagues internationally also advocate for, is really starting with, from a pharmacologic standpoint, starting with I'm not a psychiatrist, but an SSRI, something to treat symptoms of depression and anxiety before moving to an antipsychotic, and really having a very high threshold for antipsychotic treatment. Omega-3 fatty acid, or fish oil, was another one that seemed to show some looked really promising early on. There was a big study showing that it substantially reduced rate of conversion to psychosis, but that was not replicated, unfortunately. So and then CBD is another one that I believe there's a current clinical trial ongoing. So there's a lot of things that are in the works, but thus far, nothing that's really shown to be a slam dunk.
Okay, next question is, do you know if clinicians are using the risk calculator in practice, and do you feel it should be utilized in practice at this point?
Yeah, good question. So one of the challenges with the risk calculator at the moment, so it's been used quite a bit in research settings, but I think much less in a standard clinical context. And one of the challenges is that, and a big caveat is that this is a risk calculator for people that meet these clinical high risk criteria. And so it probably would not work the same. I'm almost confident, quite confident, would not work as well, or you would not get the same results in a general population, for example, a pediatric clinic. And so what I think is the best screening strategy is taking a screening measure like the prodromal questionnaire, which is a self-report questionnaire, using that as a screening tool, and then referring for a more detailed evaluation. So I think that's a more, sort of clinically actionable approach.
So next question is, you talked about the sort of different levels of false positives with different thresholds. And I think the question is, how do you make the decision? Whose decision should it be to determine what is the optimal level of false positives? What is the optimal threshold?
That's a great question. And I wish I had an answer. I mean, this is something we struggle with a lot. And basically what we can do is to provide the information to the families that, based on our current knowledge, you meet these criteria. However, there's a lot that, this doesn't mean that there's any, nothing is definitive, nothing is deterministic. There's a lot of hope. And a lot of optimism that, the majority of people that meet this criteria actually do not develop a psychotic disorder. And there's also evidence that early intervention does make a difference in changing those outcomes. So I don't have a definitive answer of what is the right cutoff for that. And sometimes, we do have to make a decision. We do inform people, but we stay pretty symptom focused, and try to give people the information that's most appropriate for their particular situation.
Yeah, so I guess I have a follow-up question to that, which is, I certainly understand that at an individual level, there's no right answer, but I wondered whether either your group or others are looking at it from sort of a society standpoint about, sort of in terms of resources and,
Mhm.
is there any kind of analysis of sort of that, from, let's say, a health economic standpoint?
Yeah, that's a really good question. And I think some of the groups in Europe are doing some of that work. And so Robin Murray, I think, is, his focus is really on reducing cannabis as being, thinking that that is a modifiable risk factor that, something can actually be done about, whereas some of these other risk factors are, it's unclear, how well you can actually get in there early on and intervene. And so, but cannabis is something that he feels very strongly is something that's modifiable. And we certainly do see that it increases risk, and there's a question of whether it increases risk even in the absence of a genetic predisposition, but it seems like there's, particularly with modern day cannabis, it probably does. So, I think that at this point, there is a big question about whether, these early specialty care clinics, which are, they do require a lot of combined biopsychosocial treatment. And so I think, no, I think it's a really important question.
Okay, so here's a question that relates very directly to clinical practice from someone who is interested in using the FFT in practice and is asking whether it is manualized differently from that in the Miklowitz book for the CHR patients. Is wanting to make sure that they use strategies that are the most supported by research.
Thank you for that question. Yes, we do have, it's not dramatically different, but we did develop a manual, and there are, feel free to email me. There's a couple of papers out there. There's one, a new paper on our protocol for our new trial, and there's a couple of other papers that describe the CHR adaptation for the family-focused therapy.
Okay. And so here's another comment about pharmacology. I don't know whether I'm pronouncing it right. I think a new combination, Lybalvi, Lybalvi, which is a combination of olanzapine and samidorphan, which has been shown to mitigate some of the weight gain that comes with olanzapine, while providing effective treatment. And do you know if any studies are being done on this medication for adolescents right now?
That's a great question that I am not aware of any. And if there were something being done in the clinical high risk space, I think I would know. So I don't think that's going on currently.
Okay. And I think we have time for one more question, which is, in speaking to families, how early is early?
Yeah, so one of the challenges is that we see people at varying points in terms of how severe their symptoms are. And so, I showed you that with the dimensional severity. And so, so we give people feedback on their current level of severity, and it's and try to stay very individually focused as much as possible. So, and I think the less severe the symptoms are when they first get to us, then certainly we know this from our risk calculator, then the better the outcome and the better chance that they're actually not going to go on to develop a psychotic disorder. So I think that's really important feedback that can be provided.
Okay, so we actually have one more minute. And so last question. Since kids and adults seem to use CBD more today in certain populations, do you think there might be a bimodal distribution that it can help some but hurt others from becoming psychotic?
Yeah, boy. I do not know the answer to that, but it's certainly, I think that for our youth who have who are basically not going to stop using cannabis. The suggestion is, well, if you're not going to stop, perhaps you could do something that's higher CBD and less THC content. So, we try to work with them. It's certainly, there, as I mentioned, there is a clinical trial for CBD going on in Europe. I don't think it's started yet, but I think that may tell us, that'll be really interesting.
Okay, so thanks, Carrie. I think that's all we have time for. There were a couple other questions that maybe didn't get completely answered, but I think Carrie's indicated you can feel free to email her with your questions, and otherwise, please join me in thanking Carrie for this presentation.
I'm easy to find online, so feel free to email me with anything else. So good talking to you all.
Okay.
All right. Thanks, Nelson. Thanks, everyone.